Okay, so welcome to board review. You've all had the course a couple of cycles before this, so the rules haven't changed, but the curriculum has changed a little bit. The ABFSE, I believe, a year and a half ago, had come up with new guidelines and a new curriculum, so I've adjusted the course to that, figuring that a year and a half from when they changed it should have given the conference ample time to have made all their changes in their, in their testing and their test questions. The stuff that I'm not going over that is no longer part of that. You don't have to try to erase that from your memory, but you will probably not see that. And there are a few additions that I'll highlight, and for the most part the additions are from other courses, like the tissue section is straight from anatomy, so that should be just review of material you have already learned. So let's, you have a packet. I think the last time we were together you may have received 2 packets, but I distilled it all into 1 packet, so the whole course is basically in 19 pages. It has everything that you really need to review before you take the test. I would just recommend maybe a day or so before just buzzing through this again, just to be familiar, so that when you go in you can just nail it the first time. So remember the definition of restorative art, being dealing with the care of the deceased to recreate natural form and color. What's the embalming definition basically? The embalming is basically the temporary disinfection, temporary preservation and disinfection. But you really can't have one without the other, especially the disinfection part. Hopefully we'll be dealing with embalming and preservation. There will be a few times where you're not going to have an embalmed body, but you'll have to do some, but we're a little limited to what we can do. Remember our obligations? Does that ring a bell?
Professional, to family, no?
Right, exactly.
Professionalism.
Yes, we're dealing with the psychological effect on families and friends is probably the most important one. Creating that memory picture that people talk about. The big thing is that people need to see in order to believe, or at least most of us. There are a few people that can just sort of make it all work in their brain, but for the most part we need to see to believe, and we want to make sure that people have that opportunity. In addition, we want to make sure that when the people have that opportunity, they go in, that they're not freaked out, that it's not a horror show, that they're not turned off by what they see, because a few things will happen from that. Then they'll decide to maybe not have services in the future, or they'll decide, oh, we don't even need any embalming, we don't need anything, we're just going to make it disappear. And in addition to hurting the business of funeral service, we're also affecting the people, because then they're not going to have that seem to believe. So it's an important thing. Our other obligations, like I just alluded to, is the obligation of the profession, and then of course the third obligation is personal satisfaction. Those are the 3 biggies. Some of the definitions that we have seen and covered in the past. Remember, the one was physiognomy, which is dealing with just structure and superficial, just the way things appear, has nothing to do with function at all. Asymmetry was a big one. I hope you remember your first quiz with that. Remember, asymmetry, as we covered, was not symmetrical. There's differences between the sides, the pairs, the halves, and for the most part there is a little bit of asymmetry. But we're always going to endeavor to make a person, make the features and everything appear symmetrical. We're not, if the mouth, when you open the bag, the mouth and the nose don't exactly look that good, we're not going to say, oh, well, since no one's ever really totally symmetrical, we're just going to leave them that way. No, we're going to try to adjust, make things, as symmetrical as possible. You're going to know when they never were symmetrical before and they were never meant to be that way. And that's something you'll learn over time as you practice. But if you also remember the very first quiz that we had, I didn't give you a question on asymmetry, I gave you a question on symmetry. I don't remember how you all did, but it depends. Classes cycle. Sometimes almost everybody aces it, and then there are those times where the majority of people, they just totally let it go because they've just sort of memorized and say, oh yeah, that was asymmetry. So nobody talks the way I do, nobody teaches the way I do. So when you're taking a test written by another person, don't just automatically pop out with an answer that's similar to what I've covered in the past. Make sure you know what they're covering
Can I ask
and what they're
questions? It's
asking.
open-ended, like, is that okay? Yeah, I don't want to interrupt. Most of the questions that we get, right, the things, what's that?
Are you talking about exam?
Yeah, I can't talk about. Oh, okay.
Okay, very good.
Okay.
All right. The other big definition that you'll see from time to time is norm. Remember what norm is, the most common characteristics of each feature. We'll talk a little more about the canon of beauty later on. But you know, there is that norm, there is that baseline that we want to deal with, the most common characteristics, and that's our norm. A big thing when answering questions about scenarios or other things is dealing with the timing. If you have a complex question, a lot of times knowing when things are done will help you to back into the answer if you're not familiar with everything. Prior to embalming, we had a lot of things that we could do. And I'm just going to read them out real fast for just a moment. I'm talking about, posing features before the tissues settle, corrective alignment in nose and jaw, holding muscles or flaps of skin together with temporary sutures, resetting dislocated features or fractures, repositioning displaced tissue, minor buck teeth correction might be one that you remember, puncturing blisters, suturing clean cuts, supporting surface tissues when bone is depressed. So the key to this, what's the one key, what's the one thing that's in common with most of this? Yeah, the big thing I see is basically alignment. We're getting someone into alignment. We're getting everything repositioned the way it should be. Before we inject the chemical, before we firm the tissues, and then make it harder to make alignment
Does that
corrections
include the
later on.
compound fractures?
Absolutely. All fractures, whether they're simple or compound, should really be realigned. We're going to set features. We're going to do all of that before we go. The only one that might not make total sense, but is there, is suturing clean cuts. That's textbook, and that's what we'll go by for now. And then you'll see how things go as you practice. During embalming, that's the shortest list of things that we had. Basically, when we're embalming and we're injecting, we're doing a little bit of tissue coloring because we have dye in the chemicals. All of our chemicals have a little bit of dye. You can also add dye to it if you want. We have some internal tissue building because as we inject, we can also start to plump up things, maybe raise the eyes a little bit, plump up the lips, make them look a little better. We're also going to be maintaining posture and positioning of the features because as we settle those features, the features are going to, fall back. And we want to, keep positioning. Maybe the mouth is going to open a little bit, or the eyes are going to move. So we want to keep on top of that. During embalming isn't, smoke break time. This is still a very active time to keep right on top of things. The other thing that we have to keep in mind is we have to be careful to limit swelling, because embalming can cause swelling. Especially if we're injecting upwards to the head, the eye could start to pop out. If we're doing an autopsy case, we could easily make pop-eye arms and thunder thighs. So as soon as things start to swell up, we have to know to stop, reassess, decide what to do before we proceed any further. And then, of course, most of the work, the majority of the work is done after embalming. That's where all the magic happens, right? It's hypodermic tissue building, removing scabs, excising mutilated tissue, suturing incisions, reducing swellings, our deep wound prep, all of the wax work that we do. And I think you may have remembered that we talked about 8 to 10 hours after embalming is when we'll do the wax, because it takes a little while for everything to firm up. Feature modeling, bleaching and masking discolorations, of course external cosmetics, internal being the embalming. That's when we put everything together as well. Attachment of dismembered parts, simulating missing parts, correcting of unpreserved areas, major buck teeth correction. We also took our treatments and we divided those up into whether or not they were minor and major. Basically, you know, minor restorations were those requiring minimum time of skill, and major were requiring a long time to complete. And then there were a few that required technical skill. I'm not sure that's important anymore, but we'll still keep those separate for now. So on the minor restorations, basically correcting a misaligned feature, hypodermic tissue building, minimum skill, still requires some skill, reducing swellings, subtissue surgery of mouth or eye, waxing lips, abrasions, razor burn sutures, suturing clean cuts, small hair replacements. That almost sounds scary, but a small hair replacement does require minimum time and minimum skill. Bleaching or concealing discolorations, removing scabs. Those are all the minors. The regular major restorations, restoring a full head of hair. Now we're still not talking technical skill, we're just talking a lot of time. Subtissue surgery of neck, major correction of buck teeth. That should be an easy one. Major is major. Deep wound and laceration prep, repairing and reconstructing multiple fractures, third-degree burns, skin slip, and realignment of dismembered limbs, decapitation, missing parts. And then the ones that require technical skill, that's artificially reconstructing a distorted face or cranium, waxing large wounds, cheek, forehead, or neck, modeling facial features, of course. Then we have the matching wax with complexion and achieving a natural appearance when masking a discolored face. Anybody can take the paint and paint up the face, but then to make it look really, you know, lifelike or somewhat natural, that takes a little more skill, because we have to add some other colors and shadows. And then for the most part, okay, then just a few more definitions. Remember, projection, that's jutting out in comparison to an adjacent feature. If something is prominent, it's standing forth, is readily seen. A recession, that's something that's moving back to a more distant point. And with depression, we're talking about something that's sunken or concave. And we'll talk more later on about concavities and convexities. When we covered racial differences, there were just a few keys, and I'm just going to give you the keys that I believe would be helpful. When we deal with a white person, one of the keys is a high cranial vertex, thin lips, narrow nose. Those are the three keys that I see. The other things that we talked about was basically hair almost any normal color, and you know, the eye color, any normal color. Moving to black, we had a low cranial vertex with that, thick lips, and a broad nose. Not a lot of hair variation. Not a lot of other information that I recall to be important for you. And then we had mongoloid or yellow, and that's a high cranial vertex, small nose. And remember, the other thing that comes to mind is the distance between the corner of the eye to the root of the nose is minimal. But for the most part, if you were to see a question about this, hopefully you're going to see something that's going to talk about either nose or lips or the cranial vertex. If the cranial vertex is there, that's going to be a real help, because if they say low cranial vertex, you just want to make sure that everything else is going to match black. Mm-hmm. If you see high cranial vertex, then you have a 50-50 shot of getting it right. You can eliminate black right from that equation, and then just look for the nose and the lips and see where that puts you.
Are we getting into those scientific terms about the different racial differences?
Nope,
No.
nope, that's all you need.
Okay.
We're gonna keep it nice and simple.
Okay.
Yeah, simple's better. The bones are thin and mostly convex. The skull is oval or egg-shaped. The width of the skull is 2/3 the length. That's a biggie. The width of the ear is also 2/3 the length. I'll have that later on. The adult face is half the size of the cranium. We don't have to worry anymore about the infant's face or the growth of the infant, so that's something that disappeared. 6 surface bones on the cranium. You have the occipital bone. I remember in the past we had 2 or 3 different things we had to learn. The only thing you have to remember about the occipital bone at this point is the Friedman magnum, the large opening, for the vertebral column. Parietal bones, they have a vertical and a horizontal portion, and the big thing to remember there is the change from vertical to horizontal, is at a place called the parietal eminences. And we're going to talk more about the parietal eminences in just a little while, because that gives us a measurement. The temporal bones, the things that you have to remember, the zygomatic arch is probably one of the easiest things for you all to remember, because I remember when I had anatomy, they really made sure that we understood that well. The squama, that's the small, convex portion that's medial and deep. The mandibular fossa, the mastoid process, external auditory meatus, all straight out of anatomy. Nothing special about those. And just a reminder, the widest part of the face is from zygomatic arch to zygomatic arch. And I know I have all the measurements coming down later. The frontal bone, we got 4, I don't know if you had 5, but now we only have 4 prominences or eminences to remember. The frontal eminences, those are the prominences on the upper part of the forehead. Kind of think of Herman Munster, if any of you have ever seen that old black and white show. The superciliary arches are right above the eyebrow arches. The glabella, that's that small smooth elevation between the arches that's right above the nose. And then the supraorbital margins, so just looking at the name, you should know that. That's the upper rim of the eye socket. So that's the whole cranium right there. Then we have 2 zygomatic bones. And everything on there is a process to whatever bone it's touching. And from the center of the zygomatic bone to the center of the other zygomatic bone, that gives us the widest part of the central plane. That could also be considered the anterior plane, the frontal plane, the medial plane. 2 nasal bones, which are right to inferior to the glabella. The nasal cavities, which are slightly irregular. The mandible we spent a little bit of time on. The big thing, the mental eminence is the chin. And then we have the incisive fossa, which is the depression between the mental eminences and the incisive teeth. And then we spent some time on the ramus of the mandible, that the angle of the mandible actually changes with time. And I gave you all the measurements right here. So at birth, the angle is about 175. At 4 years old, it goes to 140. Right now we're all at about 110 to 120, and then we head back towards old age a long, long time from now. That'll be going back to about 140. The maxilla, that's another one that had a lot of processes on it. The frontal process, the zygomatic process, the alveolar process, that's the sockets of the teeth, which is the same thing. If we have alveolar processes on the mandible as well, and the palatine process, that's the roof of the mouth. What I still think is important, though, to remember and to keep in mind is what bones make up the eye orbits, if you're ever asked. So the supraorbital margin, the top margin, any guesses? Frontal bone. and just the frontal bone. Our lateral margin, we have two bones on that. That's the frontal and zygomatic. The inferior margin is the zygomatic and maxilla. Then the medial margin is the maxilla bone. And I think when you read through the textbook and the definitions, it talks about the maxilla bone as how it travels up and touches, and you know, great, that's good that the maxilla touches other things. But if you're talking just about the, you know, the eye orbit, all you want to think about is just the maxilla for the medial margin. Then we talked about prognathisms, and the basic, you know, talk of the prognathisms, that was the projection of the jaw beyond the upper part of the face, and there were 5 types of prognathisms. Remember, the dental prognathism is one. That's where the teeth insert at an angle greater than normal, you know, at an oblique angle. Alveolar, A-L-V-E-O-L-A-R. That's when the lips move forward and the chin recedes. Infranasal, anybody remember what that is? The shaft of the nose is at an angle greater than normal. Am I going too fast, or are you guys doing okay? Okay. And then the easiest of the prognathisms are the maxillary and the mandibular, because they just jut out at a, you know. If you see any questions about teeth, you know, remember, like I told you before, don't start counting your own, because you'll probably be wrong. We have 32 of those. 8 incisors, 4 canines, 8 premolars, and yes, 12 molars.
I have a question. When they talk with the teeth questions that we've learned through this, it's only with the alveolar.
The alveolar process.
That's the only process that has to deal with the teeth, right?
That's correct, yeah.
Okay.
Well, now, if we're talking about alveoli,
Yeah.
then we're talking about,
That's the one.
then we're talking about the air sacs in the lungs.
Right.
But that's not an
You
alveolar.
can tell the difference in the
Yeah.
spelling, but it's, yeah, okay.
And it's not a process.
It's a, okay,
Yeah.
just making sure. I'll probably stop you a lot, but.
It's quite all right. We want to make sure you nail this.
Exactly.
Okay. And remember, the 4 parts that exhibit a bilateral or horseshoe curvature. I know every course I have, there's always someone that comes out with a few more that could be possible. But for the ones that I found in the textbook, which you'll probably see, would either be the upper integumentary lip, the cheeks, forehead, lower jaw. Those are the 4 biggies. And like I said before, here are the 4 widths that we need to know. The widest part of the cranium is parietal eminence to the opposite parietal eminence. Widest part of the face, zygomatic arch to opposite zygomatic arch. The central plane, which we spoke about a few moments ago, the center of the zygomatic bone. And then the widest part of the neck is the widest part of the SCM to the opposite side. Okay, then we had muscles. We finally got finished off our bones and everything. And the muscles, 2 muscles of the cranium. I believe we got rid of 1. So that's good. The temporalis, fan-shaped muscle right on the side of the face. That's the strongest.
Broad?
Yeah, broad radiating. Yeah.
Broad fan-shaped muscles, right?
Yeah, that's right. Yes, it's the strongest chewing muscle. I know that's the muscle of the cranium, but for some reason they love to say that that's the strongest of the chewing muscles. Then the occipital frontalis, also known as the epicranius. The 2 broad flat bellies that are combined with the aponeurosis, right, the gallia aponeurotica. The occipital and frontal bellies. Then we move to the neck. We have 3 muscles still. two broad, flat, superficial muscles covering the the collarbone, shoulders, upper ribs, the platysma. So when we go to raise the carotid artery, the first muscle we get rid of is the platysma, and then we go down deeper to the SCM muscle, and we then separate that out before we get in danger of nicking the vein and having to stumble. And those are the thick muscles that obliquely run across the neck. The only other muscle of the neck is digastrigus, and that has the two bellies that are right below the body of the mandible. Then we had a lot of muscles with the mouth. So basically, we talked about mouth, we were thinking about the mouth and below. Now remember, as soon as you see orbicularis, anything, slow down, take your breath, make sure you figure out whether or not we're talking about one mouth, two eyes, because invariably, even on finals, people, I have to say it has to be nerves, because I try not to make the questions that hard, but people just get so nervous with a 150 question final. But just try to slow it down, catch your breath, and just think, what is he really asking here? And the oris is a sphincter muscle that encircles the mouth.
Singular, you said? I didn't hear the first one. What
Sphincter.
Muscle? Sphincter muscle.
Sphincter muscle, yeah.
That covers the mouth, you said?
Mm-hmm. And we have the depressor anguli oris. That's an oblique line of the mandible, also known as the triangularis muscle. And
oblique what?
it runs to an oblique line of the mandible. And the depressor labii inferioris is also, an oblique line of the mandible as well. And that's also known as the quadratus. And right smack dab in the middle, right between the two quadratus muscles, is the mentalis. We'll talk more about that when we talk about dimples in a few minutes. And then we move to the face, which is above the mouth basically. Remember the quadratus labii superioris, the four-sided muscle with three heads? Superficial to the upper lip. And then, was it levator labii superioris aliquae nasi is the medialmost head. Then the levator labii superioris is the intermediate head. And then the zygomaticus minor, remember minor, zygomaticus minor is the lateralmost head of the quadratus labii superioris muscle. And lateral to the zygomaticus minor head is the zygomaticus major muscle itself, right? Also known as the laughing muscle. The levator anguli oris, just look at the word, that raises the angle of the mouth. And that's the only other key that I have for you on that is that it's in the region of the canine tooth. The buccinator, that's a four-sided muscle on the side of the cheek. And does anybody remember the AKA for that?
I was going to say laughing.
No, laughing is the
Right.
zygomaticus major.
Right.
So this is the trumpeter's muscle. Now basically in the very same spot is the risorius. That's the narrow superficial horizontal muscle running across the side of the cheek. So that runs sort of on top of the buccinator. And then the last one is the masseter. That's running in the anterior 2/3 of the zygomatic arch. And then we have the muscles by the eye. And by looking at these words, a lot of times you'll be able to figure things out. Levator has to be raising. So anything that's levator has to be above the mouth. It's certainly not going to be in the lower part of the mouth. Palpebrae, that has to do with the eyelids. Superioris, that's basically the upper eyelid. That attaches to the sphenoid bone. And that's the only time you see that bone in our course. I know you had that a lot in anatomy. Procerus, that's the long, thin, vertical muscle going up the forehead. So that's going to be overlapping the epicranius. The corrugator had a nice AKA. Frowning muscle. The frowning muscle. And that's at the medial end of the eyebrows, which is basically on top of the orbicularis oculi muscles. So whenever you see orbicularis, just catch your breath. What are they asking for? And then we have the new stuff for this course, which is old stuff from anatomy is the integument and subcutaneous tissue. If you want, I could probably email you the new lecture. I've recently finished that. Remember, derma, that's the deepest skin layer. The epidermis, that's the outermost skin layer. And complexion, we get complexion with the blood coursing through our veins. And we also have those two pigments, the melanin, M-E-L-A-N-I-N, and carotene, C-A-R-O-T-E-N-E. So the melanin gives us the dark color. It becomes more apparent when we get exposed to the sun. And then the carotene, that's more the yellow, the sallow color that we see more in older people. And then with subcute tissue, we have the fascia. That's connective tissues. It's in two layers. It helps with, with the movement of organs and everything. And of course, adipose, which is fat. That's a type of connective tissue. And we have basically three types of glands. They originate in the dermis. And you either have oil, sweat, or wax glands.
Oil, sweat, and what?
Wax.
Oh.